Mm, that is, is it there? It is. Mm, okay. I'm seeing the name Caris. Caris, what did you learn yesterday? Oh, any shortcut. You wanna if you let me tell you, if you want to learn and this is just a joke. If you want to learn and remember it forever, uh, add emotions to learning, emotional events that your mind will never forget. Okay, Carrie says she was in here. Barnabas, how are you? How are you,
I'm fine.
Barnabas? Were you here yesterday?
Oh no, I couldn't join.
Okay. Who was here yesterday? Mami Pokua. Mami Pokua. Mm. Google Pizzo, I'll come to you, okay? Hey, so you see, you were iPhone Mary. That is someone's name. Jesus. iPhone Mary. Yes, I'm listening. So nobody was here yesterday. I can't say anything we did yesterday.
Sir, sorry, I got up.
Okay.
Yesterday we talked about heart failure in children. That's what I remember.
Okay.
Yes,
And what did you learn?
and we said that the heart failure in children, it's when they have some heart conditions that causes their heart failure.
Mhm.
So they have poor feeding and they cannot grow well.
Okay.
Yes, and we said that the medication we give them is digoxin.
Okay.
Yes, something small I can see.
Wow. Yes, who else? David. 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 Hmm? Oh. You people, why? Why are you quiet? Mhm. Somebody knows the thing. He's online. Doesn't want to talk. Mm. Why are you? People Mensa. Okay, Matilda is saying pediatric conditions, we did heart failure, spinal bifida, meningitis. Okay, right. And oh, is it Adi? So Adi, can you hear me now? Can you hear my voice now? Let me know. You can send me a message in the chat box. Okay. So let's start. Nobody wants to talk. Let's start. Okay. Okay. Right. So we got to spinal bifida yesterday and we did the types and we know what happens with it. We did the physiology. Okay. And we also saw how to protect the sac and manage it as a nurse. Okay. Yeah. So today we are continuing with cerebral palsy. Cerebral palsy. Okay. Yeah. So cerebral palsy is a group of permanent disorders affecting movement, posture, muscle tone, and coordination that is caused by damage to the developing brain before, during, or shortly after birth. Okay. So the brain injury is non-progressive. What does it mean? Meaning it does not worsen over time, although symptoms may change as the child grows. So that is cerebral palsy. Yeah. So this is non-progressive motor disorder from brain injury. Yeah, it can occur before, okay, birth, during childbirth, or shortly after birth. Okay. So you see the children exhibiting all these muscle spasticities, okay, poor coordination, delayed milestone. Let me show you a picture of it. A child with cerebral palsy. I don't like this. Yeah. So children with cerebral palsy. Good. This one. So it's a lifelong. This child got the injury before, during, or after any of these three stages. Okay. Yeah. Got injury with childbirth, and it happened this way. Yeah. Okay. So all these children, they have issues with what coordination, movement, and muscle issues. Okay. It's a motor disorder. So it is not a sensory disorder. It is a motor disorder. So that is what you should know. Mhm. There's definitely going to be a delayed milestone. So this child, looking at this child, he will be more than 6, 7 years. Okay. But somebody will be feeding him. Look at this child. He can be more than 10 years. but somebody will be feeding him. Okay. Yes. So all these motor issues, growth and development, it will be affected when you have cerebral palsy. Okay. Yeah. So these are the things you should know when it is not their fault. They develop brain injury when they were being born or right after birth or before birth. So that is cerebral palsy over here. Okay. So I have seen some picture here. Let me keep showing you. Okay. So you see your motor centers. So ataxia, see the attitoid, there's uncontrollable movement and spasticity, stiffness, and all those stuffs. So it affects the the muscles. It can affect your hand. It can affect half of your body. We call it hemi. It can affect. This is a vertical half, no horizontal half. Okay, so we call it what diaplegia, or leaving only your head. Okay, so a child, as the child is growing and developing, all these muscle functions should work. Mm, all the muscle functions should work. Okay, but if you're having issues with motor functions, where did the damage come from? That is what we are looking at now. Okay. Yeah. So that is cerebral palsy. These are some of the conditions. And as we started yesterday, we are on disorders of what the nervous system in pediatrics. When we say pediatrics, we are looking at from day 0 or day 1 to what 18 years. The problems and the challenges they get as they are growing during childbirth. Okay, perfect. So if today is the first time of joining us, this is what we have been doing over and over and over. We started with maternity and we are with pediatrics now. Okay, let's look at another nervous system problem children get. They mostly, or some of them will also develop meningitis. This is a medical emergency with what pediatrics. Okay, yeah. So this is the brain. This is the spinal cord attached to it. Okay. God will create a cushion, a covering, okay, around it. Okay. Curtis, where are you? Let me do a piece for you. This is a cell. Curtis, where are you? On your camera, on your microphone. Let me know if you are there. Let me know. Oh, Ellen, which structure covers a cell? You are doing a game of covering. So which structure? This is a cell. So which structure will cover a cell? Yes, who knows?
The memory.
The memory.
Okay. The membrane. You are dealing with animal cells, so you say membrane. Okay, perfect. Which structure covers the heart?
The pericardium.
Yes, who knows? Pericardium. Okay. Which structure covers the lungs?
Pleura.
Right. Okay. Which structure covers the kidneys? Or let's take this one. Which structure covers the adrenal gland?
Adrenal cortex.
Yes. So every structure God has created inside a human being has a covering. Which structure covers the whole human being? Yes. Who knows?
The skin.
The skin.
The mighty skin.
Skin. The skin will cover everything. Okay. Good. So when we take the central nervous system, that's the brain and the spinal cord, we will get what? The meninges covering it. Okay. Back to this game again. This was the cell. If the cell gets, you said the cell membrane gets infected, it is going to affect what? And you don't treat this infection or get injury and you don't treat it, it is going to what? Affect the structures inside. The same way the heart, the lungs, the adrenal cortex, okay, the skin gets infected if you don't treat it or get inflamed, whatever, injury, trauma, it affects body organs inside or internal structures. So when the meninges also get infected, it will affect what? The inside structures. And the inside structures over here are the brain and the spinal cord. You got it? Yeah. So the infection of the meninges is called meningitis. Anytime you hear itis, this word attached to any name, about 95% of this itis is caused by infection. A certain microorganism is causing infection to that structure. Yes. So itis, we can't treat itis without thinking about infection. That is what you should know. So when the meninges gets infected, you will see the brain and the spinal cord in trouble. Okay. So you're going to experience this stiff neck. Imagine this is your brain. This is your spinal cord. This covering here has been inflamed. Okay, so this one is inside the human body. So this is the head. And this is the neck. And these are the shoulders. So if this one gets infected and you bend your neck like this, you are going to stretch the meninges. You are going to experience, in that case, you experience some severe neck pain. Okay. So what happens? Where there is pain, there is loss of function. Nobody wants to use their muscles or use their structures when there is pain associated with it. So nerve thickness is very important. Okay. You are dealing with nerves, photophobia. Photophobia is going to also occur. Why? Because when you see light, the light must go straight to your brain for interpretation. Okay. But here is the case. The structure covering the brain is infected or is inflamed. So it's going to affect what? This process, nervous process ongoing. Okay. In severe cases, you can even experience, or patient can experience, altered level of consciousness. Okay. How will this child cry? High-pitched cry. Okay. High-pitched cry. For children, this is the characteristics. Then bulging fontanelle, especially the anterior one. The bulging fontanelle is very important. Yes, your antibiotics is very important. Then your droplet precautions is very important if only you rule out infections. Okay, so that is what you should know. Okay, that is what you should know about meningitis. It is a very beautiful subject. Okay, so on this note, we say goodbye to the nervous system. Now let us come down. We have done the nervous system. We've done the cardiovascular. Okay, let's go down. Let's go to, and we've done respiratory. Let's go down. Assessment. Let's enter into the gastrointestinal system of pediatrics. One of the conditions they get is what? Gastroesophageal reflux diseases. The GERD. Gastroesophageal reflux diseases. Gastroesophageal reflux disease, or the GERD. It is very common in infants due to immature all these lining and all these structures in their GIT. Okay, or immature lower esophageal sphincter. Yes, so if this is the GI tract is very long. Start from the mouth to the anus. Along the line is divided into two, where the top here is called upper GI, and the lower here is called lower GI. The GERD can be found in the upper GI. Why? Because in the stomach, there is an acid that is being produced always. Acid that is being produced always. So if you think about food or you eat food, yes, but sitting on top here is what? The sphincter, the lower esophagus. You will not see the esophagus inside the stomach. The esophagus ends here at the top here. Okay, yes, it starts from the top here and ends at the bottom here. So there is a sphincter here. A sphincter here. And the duty of the sphincter is to what? When it opens, food will pass to the stomach and it closes and prevent backflow. But because children have weak, this side, this sphincter, there's that flap, muzzle flap, because it's very weak and immature. That's the word here. Immature lower esophageal sphincters. The least then it opens and acid will move up, or gastro. So if you have realized Those of you who have babies and children, the least thing you have fed your child with what breast milk, but the least thing you see what them vomit. Where did that food pass to enter their mouth? And it's out as vomitous. You fed a child with breast milk, but if you don't bear this child and there is a lot of gas inside the stomach, you regurgitate. You regurgitate. Gas is another organ, another structure or another thing that causes the stomach to be easily full, and it will bring the food out. It will push against the sphincter and open it. Yes. So because here is full of acid, it flows back and bends the esophagus. Okay. Yes, it bends the esophagus. Yeah. So there is, if you see the children, regurgitation, irritability, and poor feeding. Yes. That burning sensation will make them, very restless, irritable, pain, crying, and all those stuffs. And they are not comfortable to eat again. Okay, poor feeding because of the pain, the esophageal pain. Okay, so we advise that when you are giving these children food, it should be small and frequent. Also, they should sit upright after feeding. Ayarigo has a strong sphincter. His child does not have that strong sphincter. There are some adults too, with time, their sphincter becomes weak and it also gives them issues. Okay. Other than that, generally, adults have stronger sphincters than children. Okay. You should sometimes too, you see the food and nutrition guys or the nutritionist will prescribe based. So we do an analysis, assessment. We will assess your nutrition, okay, and know which food will be okay for this child. So we have a certain powder. When we put it in liquid food, it solidifies it. It makes it like a gel, gelatinous. We call that powder thickener. Thickener. So we thicken the food. It's like lactogen. Okay. So if you pour lactogen in water, that powder is like lactogen or this food formulas, that powdered formulas. Okay. But the duty of that thickener is to thicken the fluid. So you make it a little semi-solid. There are some adults who cannot swallow solid food. So, but we can't say that we will not give them food again. So what do? We make it, we get them liquid food. Then we put a little thickener. So the LDDS, whatever, or IDDS, and the how do we call it? Dysphagia assessment, the difficult swallowing. We do the assessment, we do the grading, then we know how many scoops of thickener should we give you. So the nutritionist is the duty of them to come and assess the patient, and they do the prescription. Okay. Perfect. Now let's go to pyloric stenosis. Pyloric stenosis. When we say stenosis, something has become thickened, and it is almost closing or obstructing an inflow. Okay, so this is your, let's say this is the GI tract. It will get to a point that this side will become thickened and hot and almost closing. So any food that gets here, it cannot pass to this down here. So what happens? Patient can vomit it out. Okay. It happens in children. And when it happens at the pylorus, the pyloric, okay, mostly at the pyloric sphincters. Okay. We call it what? Pyloric stenosis. So the hypertrophy of the pyloric muscle. Okay. The pyloric muscle, we don't know what is happening to it. It is hypertrophying. It is multiplying. It is becoming plenty. The muscles are adding up. Okay. Yes. So that is the muscle between the stomach and the duodenum. So if this is your stomach, and that's the duodenum. Remember, the duodenum receives the head of the pancreas. So they are always like this. Okay. Who can tell me why the pancreas is here? Ayariga, can you tell me?
The little I know, I think that is where most digestion takes place, and the fatty, certain digestion is really fatty food digest. So when this thing is produced for fat emulsification or something, I don't know, I might be wrong.
You're right. Okay. It is a beautiful anatomy that if you have forgotten, go back and read your books. Okay. So, this is your pancreas. That's the duodenum. Okay. There is a gutter. Let me use the gutter or a channel. We know gutter in our homes when we build houses for drains. Okay. Yes. We call it the pancreatic duct. This gutter. Okay. So David has eaten carbohydrates. The pancreas will release what? Amylase. Enzyme we call amylase. Okay. Somebody has eaten, I can see Grace. Grace ate fat. The pancreas will release the hormone or the enzyme to digest this fat. We call it what? The lipase. Okay, and it goes on, all these pancreatic enzymes. Yes. This is not an endocrine hormone. It's an exocrine. That's the exocrine function of the pancreas. So when they release from their cells, and it gets here, it will roll or to flow to what? The duodenum. So Ayariga ate banku. Banku is in the stomach. When the banku gets here, the amylase will deal with the carbohydrates, and the lipase will deal with the fat, the soup, the fat in the soup, and it goes on, it goes off. Okay. Yes, these ones are coming from the liver. The liver is sitting on top here nicely. The liver will bring so there is a duct here. Sitting below the liver is what? The gallbladder. Okay. The gallbladder stores bile. It stores bile. So we have the gallbladder will bring the duct. Then the liver too will bring their duct. Then the two of them will join to form the common bile duct. This common bile duct will meet with these guys. and they will flow to what? Duodenum. That is it. Okay. Now let's go back to this. I haven't ate banku here. But the stomach, before the stomach would become a duodenum, there is a bridge. Adome Bridge. Those of you who have traveled to Ghana before and don't know, or whichever country you are coming from, there is a certain road. There is a town here, and there is another town here. People here want to go here, and those here want to come here. But there is a sea or a river here that, yes, people will choose to use boat to travel. But how many people can use boats within the same time? Okay, so let us create a bridge between these two guys so that henceforth, those who want to use car can cross, move up and down anytime. Any time of the day, you can travel. Okay, yes. So that is what is happening here. This is the stomach, and this is the duodenum. Okay, but this bridge is called, we call the pylorus. It is full of muscles. Okay, it's a muscle and it has a hole in it. So when these muscles, sometimes it becomes, I've told you that the cells God created us with time, it dies, a new one comes. So when the new ones are coming, they multiply faster. And you realize that the muscle here becomes big. Now our bridge has become big. And the inside too will be big. So as the muscles are enlarging, they close. So when they close this hole here, it closed. Do you think food can pass through? No. Okay. So what will now happen? Somebody will be eating, 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 eating. And when the stomach stretches, creating all abdominal pains and other stuff, a compensation from the brain will come in to solve the problem. That no, this guy has overate. He's now having discomfort. The stomach is now pushing against the diaphragm. Patient cannot breathe because he has overeaten. So what do? Let's take some of the food out of the stomach. How do we take it? Let us go to the brain. There is a center in the brain called the vomiting center. Let us go and trigger it. When you trigger it, they will send what? Motor. I've told you that senses will go and motor will bring the response. So the motor nerves straight from the brain will come to the stomach, come and churn it, cause, the muscles will be contracting, churning, then you vomit out. And when you are vomiting, this food stuff is coming with some kind of pressure and some kind of speed. So we describe it as what? Projectile vomiting. But you know the funny thing, assuming this food went to the duodenum, it would have mixed with the bile from the gallbladder, because I explained this to you. That's what the hepatic duct and the duct from the gallbladder, they come and meet at the Y junction, and they form the common bile duct. And the common bile duct will come and join the pancreatic duct. So the bile here, there is bile here, and whatever is coming, they will come and mix with this one. They go to the duodenum. So inside the duodenum, the enzyme you see here has what? Bile. It has what? The bile will emulsify the fat. The lipase will break down the fat. Okay, the amylase and all these protease and all, yes, any food substance you eat, enzymes will act on it. But because this place was locked, the food here, did it get into contact with bile? No. So that projectile vomiting the child is bringing out, let us take it to the lab and analyze. Can we find bile in it? No. So we call it what? Non-bilious. If food travel from your stomach to your duodenum and you vomit it out, you vomit, that emesis, that vomiting, we call it what? Bilious. You see bile in it. Bilious vomiting. But because this place, the muscle here has blocked the food from traveling down, this vomitus that came out, there is no bile in it. So we call it non-bilious vomit. Okay. Yes. Now food is not going. The cells inside the human, the baby, are crying for food. But this place is locked. The little that got here, instead of the mother to sit the baby down, up, they lie the baby, and the baby has vomited it out. Baby wants food. So what would they do? They can't talk. They don't have words to talk. So they will cry. Why are they crying? They are telling you that what? They are hungry. Because the food that was here is now out. So there is hunger after vomiting. Okay. Yes. And olive-shaped mass vomitus. Olive-shaped mass vomitus. So all these things, if you know the physiology, you will. Let's take the same vomit to the lab. Let's take the vomit to the lab. What will you see? You will see that what? Chlorine content is low. Chlorine content is low. Okay. Yes. Or even take take blood to the lab. Patient is vomiting. Vomiting. This is the GI tract. I have told you that this lower side of the GIT has a lot of what? Bicarbonate. And this is the base. Okay. And the upper here, Lydia, stop moving your mouse. Okay. Should I take her out? Ayariga, do something to her. Okay. So then down here has bicarbonate. Okay. And upper here has hydrochloric acid. This hydro and this chlorine. Okay. So this is hydrogen and this is chlorine. Okay. Yes. They are sitting in your stomach, and the food in your stomach is what you have vomited out. So what have you vomited? You have vomited out the food and the water you saw. Inside that water, you find hydrogen ions. And the hydrogen ions comes and mess with what? The chlorine in your stomach to give you what? The hydrochloric acid. That is why sometimes when we want to reduce the acid content in your stomach, what do? We block this one, this hydrogen ions. We call it H2 receptor blockers. Okay. When we block the hydrogen part, the chlorine will just be sitting in your stomach dancing like this because there is no hydrogen to bind with it to form an acid, hydrochloric acid. Okay, so now this child is vomiting out. You are vomiting the hydrogen acid. That is an acid. and you are vomiting what? Chlorine out. This chlorine will decrease or will cause electrolyte imbalance. So now let us go to the lab and take your blood to the lab. When the results come, we realize that your chlorine level is low. Okay, so you get something we call hydrochloremia or hypochloremia. 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 Okay, you see the child is lethargic, the child is weak, they cannot, they are crying, they are, okay, let us do ABG. ABG will come back because you have taken example. If this one was 100, this hydrochloric acid was 100, and the bicarbonate was 100, and this is the whole human body. You have vomited 50 of this hydrochloric out, so you are left with 50. But you did not vomit because the problem is on the upper GIT. You did not vomit the 8CO3 out. So the bicarbonate is what? In. So now let's go to the seesaw analogy. This was 100 acid, 100 base. Now, on the same seesaw, if this is the pivot, now your acid has gone down to 50. But your bicarbonate hasn't changed. It is still 100. So nobody has caught anything. You yourself, you have shifted your pH and given authority to the bicarbonate. So how do we diagnose you? We will say you have what? High bicarbonate and low acid. So the highest takes the diagnosis. So we will say you have what? Alkalosis. Alkalosis. Though we have not added any bicarbonate to your system, but you yourself have vomited the acid out. Hence, you have automatically made the bicarbonate the king and the ruler of the body. Okay, let's just go and analyze this alkalosis. Is it respiratory or metabolic? And I was telling you that the simplest way you can diagnose this is to ask yourself, which body part are we talking about? The second question, is that body part or is that body, that system, part of the respiratory system? Yes or no? If the answer is yes, it is what? Respiratory problem. If the answer is no, it is what? Metabolic problem. You are done. So, for example, we are dealing with the GI tract. So, when you take the GI tract like this, is this GI tract part of the respiratory system? No. So, the fact that it is no, we can't say the problem is coming from the respiratory system. So it's not respiratory. Automatically, it is what? Metabolic. Then you get it. So metabolic alkalosis. Okay, like this. So some will choose to end here, but others too are very inquisitive. They will go further and analyze. That you remember this child when he was vomiting the H plus, the hydrogen ions out. At the same time, he was vomiting out the chlorine in the stomach. So now let us go and check the chlorine content or the chlorine amount in what? In the body. Okay, at lab. So we will take your blood sample, take it to the lab. It came back and chlorine has reduced on your lab results. So you come and now add the chlorine diagnosis to it, the hypochloremic metabolic alkalosis. Then we say, salute, sir. You have done a perfect diagnosis for us. You understand why? Because the pyloric sphincter or the pylorus prevented food from going down. So this is what we do. So when you are treating this child, and remember, who can tell me the function of chlorine or the relationship between chlorine and sodium? I'm going to show you a mystery today. Have you seen children when they vomit, then they easily become weak? That they don't eat, they don't do anything. They are super weak. I'm going to show you a mystery today. Okay. And tell me the relationship between chlorine and sodium. Electrolyte imbalances. You have to learn it all. You can't just take one. You see, don't learn because of examination. Learn because you want to be a better health worker. Okay. Yeah. So that when we bring scenarios to you, yes, shoot and let's go.
So what I know is, chlorine and sodium has a positive charge and then chlorine has a negative charge, so they attract to each other.
Charlie, were you a science student?
Yes,
See, every day we go and take IV fluid. Okay. Sodium chloride, sodium chloride, sodium chloride, sodium chloride, sodium chloride. Have you asked yourself why is it that it is always sodium and chlorine? Sodium and chlorine, sodium and chlorine. Yes. So sodium has a positive charge, and chlorine, when chlorine is ionized, when chlorine, those of you who did the how do we call atom and their elements, atom, this is the nucleus, then we call this is the shell, then the electrons are on it, okay, and the shell, remember primary school, and the electrons on it, and so this is chlorine. If chlorine has let's say chlorine has 2 electrons on its shell, okay, surrounding or moving around the nucleus. And this is the nucleus. This is like the way the earth moves around the sun and the moon. Okay. The same thing happens. When all the electrons are intact, we call it what? Or we say this one is a complete element. But let one of the electrons vanish. Okay. Or let it gain an electron. When it gains or loses an electron, it becomes what? An ion. Like this. So we have what? An ion. When it loses an electron, we call it an, A-N, 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 a loss. Anatomy, antagonist, A-N, A-N. It has lost an ion. So we call it an ion. But when it gains an electron, like it gains, nobody know where he got this electron from. Your child came home with plenty money. You will be worried. Where did you get this money from? So the same thing, chlorine will gain an electron. So chlorine or that element will become what? A cation, 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 cation. Okay. In the stomach, I have chlorine here. Okay. I have chlorine here. This chlorine is complete. But somebody started vomiting out this chlorine, losing, okay, electrons, losing. So it will be what? It will become negatively charged. So when it becomes negatively charged, it attracts this positively charged sodium to it. And this one will become what? Sodium chloride, NaCl. We get a compound called sodium chloride. Okay. Why does chlorine want to be with sodium? Because chlorine, in the presence of chlorine, sodium can perform very well. Okay. Somebody is losing fluid. We know sodium will pull water to itself. But sodium can be able to pull water to itself with the help of what? With the help of this chlorine. Okay. So sodium is going, it carries chlorine in itself. Just that the chlorine is silent. Okay. Chlorine is silent. So I always say that anytime I learn this, I always remember that football player who wears the number 6 jersey, standing in the center of the field, sharing balls. You share some to defenders, share some to wingers, share some to colleague midfielders, number 8, share some to number 9, that is number 6. When you take the number 6 player out of the body, your team will lose your match. But when the number 6 player is on the field, nobody realizes the work he's doing. Unless people who are very keen with or follow football, that they know that this is number 6, he is very good. Okay. Everybody who watches football is looking at the striker, the goalkeeper, and the defender. But they've forgotten that all these people will become functional if number 6 is playing well. The same thing to the number 6 in the body is chlorine. So if you lose chlorine, sodium will not be able to perform well. So you realize that your child is getting hypochloremic metabolic acidosis. He has become weak. Sometimes they will even twitch or seizure. Where is it coming from? Because this sodium is not functioning well in them. That is why when they come to the hospital, we always want to give them what? IV fluids with electrolytes in it. Or we have that children electrolyte IV fluids. We give it to them, yes. So this child with this problem, how do we open the pylorus? We do a certain procedure we call the pyloromyotomy to open it. Okay. After you correct what? The fluid and electrolytes, you can't take a weak baby to the theater table without correcting that chlorine that is missing. Otherwise, sodium will make the child weak. So those of you who work on the children ward and at the emergency unit, they brought a child. The mother said, for 3 days, this child has been vomiting. You should know where your treatment should go. Okay. He has been vomiting. My chlorine, my sodium, my chlorine, my sodium. He say what? Do your surgery after you have corrected what? Your fluid and electrolytes. Thank you. Let's go on. We have another medical condition we call intussusception. Intussusception is just telescoping. Telescoping, okay, of the intestines. So we have intermittent abdominal pain, concurrent jelly stools, sausage-like mass on abdominal scan or CT of the abdomen, pelvis. Yes, so you see that telescoping. Okay, the telescoping of it. Yeah, these are all part of the abdominal intestinal obstructions. You have so many types. Okay, so there you see some especially where the small and the large intestines meet. You see it telescoping inside like this, a telescope. Yeah. Now, so this one everybody knows is very cheap. Those of you who are going to write exams, I will not go further to this. Okay. NCLEX or whatever will not tell you to diagnose or they will not tell you to define this. They are only interested with these ones. Intermittent abdominal pain, CT scan will show you, or abdominal CT will show you sausage mass. Okay. You can use the enema, the air or contrast medium to diagnose it. I mean, then we go to theater to correct it. Simple. Right. Hirschsprung's disease. It is one of the conditions that people learn, they forget. They learn, they forget. They learn, they forget. Some people will meet it and say, I know this condition, but I have forgotten. Okay. We call it another name or AKA congenital aganglionate or megacolon. Okay. Forget about all this name. Let's concentrate on the ganglion. Okay. Now the definition. Congenital disorder. You know that English. In which your nerve cells, the ganglion, go and look at the part of the nerves. Let me show you the nerves. Ganglion, on nerves. The ganglion, this, show me ganglion. Yes, so this is ganglion. You see? So this is a special, these people, they are just here. It's like a subjunction. Okay. They can sometimes interpret information. This one, the ganglion. So you see how the nerves travel. Okay. So this is they are coming from the spinal cord. They are tapping from the central nervous system. As they are sending the motor information here, they will meet what the ganglion on the way. Okay. Now, some children are born with issues of their ganglion. Okay. It's a disorder of the nerve cells where the ganglions are absent from a portion of the colon. That is it. When you give birth to your child and that ganglion, I didn't tell you the function of ganglion. Okay. The ganglion is everywhere on the nerves. There are cluster of neuron bodies in the peripheral nervous system that act as relay point for transmitting signals between the body and the central nervous system. That is it. Sometimes they even interpret informations. So, example, you know this baton, that running baton, okay? Before we run a baton, we start from here. This is the end. Ayaraga will start it. Nicholas is very fast, so we will put Nicholas here. Okay. And Ayaraga is here. And David is here. Okay. Then we put Curtis here. Okay. So Ayaraga started baton. Give the baton to this guy. Okay, David. David ran, gave it to Curtis. Nicholas is waiting to finish the race. When Curtis got the baton, Curtis started running the opposite way. We have a funny clip like that. Then people will be shouting, Curtis, where are you going? Curtis, where are you going? Curtis, where are you going? Curtis has disrupted what our plan. So, or when David got here, Curtis is nowhere to be found. David cannot cross this line. Because if David should cross this line, all the team will disqualify. Will be disqualified. So once David gets here, he should give the baton to Curtis. But David got here, and the ganglion, which is Curtis, is nowhere to be found. This is one of the ways to learn, so that you always remember. Put emotions to it, put dramas around it. Okay, joke around your studies. Don't be a one-way learner. You go and sit down, everybody is sleeping. You are sitting down the whole night, chewing books in the morning. You can't even remember one line. No, be playing, put drama. The brain was created to store informations with emotions. Okay, when they take you to the cinema house, 1,000 years, you will remember that one day, some day ago, I went to cinema in Accra. Okay. The first day you entered JSS senior high school, the first thing that teacher said in class, do you remember? No. But you remember your boyfriend's number. Okay. So put emotions to study. You remember? Okay. Yes. So back to this. You see, the child has a large intestine. And the large intestines, like the way we saw this nerve, we saw the nerve. Okay. This nerve is traveling to the large intestine. But you see, it has got a relay here, a center here. That child with Hirschsprung's disease, his own is missing. So how do we send informations and bring back informations? Okay. Without these nerves, the affected bowel or large intestine cannot relax normally, causing intestinal obstruction. I've told you, the motor nerves are bringing back the information. Okay. So absence of ganglion cells causes what decreased peristalsis. That will cause failure of this child to pass meconium within the first 48 hours. So there's going to be chronic constipation. Babies will be crying. And sometimes it's so funny that the health workers will rather tell the parents that go to this drugstore in town, go and buy gripe water. What has gripe water done with Hirschsprung's disease? The baby is crying. You have seen that abdominal bloating. You have seen the distension. Something is going on. Okay. We have a nerve problem. What can we do to solve it? You do surgical removal of the aganglionic segment. Okay. Yes. Otherwise, it will never relax. Until we repair it, gripe water will only relieve the symptoms, but the symptoms will come back. That is what you should know. Okay. My boys are laughing at me, David and I. Okay. Let's go to celiac disease.
Hello, sir.
Yes, Dave. Do you want to say something?
Please, won't it the gangrene won't it resolve along the process of growth, or is a must that will do surgery?
Some
And
do,
my second
but
question too is, does it have effect? Sorry, my second question to you, does it have effects on how we feel on our skin? Because it's a transmitter of sensory motor.
so this one, it will not, this is supplying the intestine. Okay, so your skin will not experience. The only thing is that the discomfort, the bloating, the reduction in peristalsis will cause that abdominal bloating. So the child will be crying, will be having discomfort. They don't want to eat, okay, and all those stuffs. You have given birth to your child. First 24, 48 hours, 72, this child is not passing that green stool. That green stool. Have you know it? Okay. What is going on? What is happening? That peristalsis has reduced. Meanwhile, this baby started feeding right after he was born. So what is happening to my relay nerves that are supposed to send these peristaltic impulses? Yeah. So that is it. Yeah. Okay. Then celiac disease. For celiac guys, their own is autoimmune. Autoimmune. It's an autoimmune gluten intolerance. Your body's T and the B lymphocytes and all these immunoglobulins, IG, they are just roaming about. Who remembers which one will be roaming about the whole body? Is it the T or the B? Who remembers? Yes. David has eaten toffee. The toffee has gluten in it. That's an example. Okay. But there is an immune indicator in the hand. I will see, though the stomach is not in the hand, but it will detect it and send information to the control center that hey, an invader has entered into the body. Okay, where are the macrophage? Okay, so the T will detect it. They are the travelers, and they will come and tell the B lymphocytes. Okay, and the B lymphocytes will produce more hot immunoglobulins to go and fight it. Okay, so the immunoglobulins, we have so many types: the E, the M, the J, and all those ones. Okay, yeah. So they'll go and fight it. Yes. So this guy has what? A disorder in which the ingestion of gluten damages the lining of the small intestine, leading to what? Malabsorption of nutrients, especially at the microvilli. That's a celiac disease. Celiac disease. Okay. Autoimmune gluten intolerance. So, yes, you, the mother, you don't have any right. You don't have any power over it. Health workers don't have any power over it. This is the gene. This is the child you have brought to this world. And the immune system, organisms controlling immunity in that child He's saying that you can give the child everything in the world, but don't give what? Gluten. Otherwise, there is going to be a serious battle. And the battle is going to happen at the small intestine. When that happens, there's going to be corrosion, destruction of this cilious. Let me show you the microvilli. Okay. The small intestine, where absorption takes place. Oh, I didn't say micro intestine. Yes. The villi. So this is, have you seen the microvilli, the cilia? The cilia. Okay. So this is how your small intestines are lined. See, God is wonderful. I swear. Okay. So that banku you ate, without these small cells, the food will come and stay in this small intestine. It cannot cross to your bloodstream. Forget. Okay. Yes. So if you take gluten and gluten gets here, it destroys this structure. This structure, it destroys it. Once this one is destroyed, food cannot cross. That is all about celiac disease. And why is it that it is only gluten? For some reason, which I don't know, which you don't know, the basics or the human being, the body, the microorganisms or whatever, the immune mediators are saying that you can give that person anything in the world, but don't try. We don't want to see gluten. So now it is your duty as a mother or as a parent or as a health worker to ask yourself, which food has no gluten? Which food has no gluten? Which food? So when the baby is young, you, the parent, will take responsibility. But when they grow, then you also tell them that, when you were born, this is what your body told me. Oh. So please, as you are going to marry, as you are going to, you are going to work in a different country or a different town, this is what your body doesn't like. Please don't go and follow friends and go and eat it. You, be parent, I've done my part. That is it. So we pass on information. Sir, please go over the part that will be destroyed. This is the microvilli. So this is the slide. It damages the lining of the small intestine, leading to more absorption of nutrients. Okay, so you are eating, the food will get into your small intestine. The microvilli or the nutrients are supposed to be absorbed into the bloodstream, into the liver, so that we can produce ATP, adenosine triphosphate. But the nutrients go to the small intestine. You have eaten gluten, and it has destroyed that absorption ability there. So how do you absorb? You can absorb. You are eating. And one thing about the small intestine is that if it sees that you are a food, you don't have any importance for the body, it will pass you on to the large intestine. The large intestine will absorb the water from it and shoom out of the body. That is why people will eat some food the body does not like. Quick, ping, 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 diarrhea. They will take you out of the body sharp. You get diarrhea, and that's it. Or you can vomit it out. They don't like it. So once the food gets there, it's like a production center. That's what you should know. Okay. Yeah. So, okay, I got you. So that is it. The gluten. You see steatoria, chronic diarrhea. I've said this. Okay. Then weight loss, because you are not absorbing nutrients. You are eating all right, but you can't absorb nutrients. Then bloating sometimes. So what are some of the food that has no gluten in it? This child who is going to be alive long until he or she dies. Gluten-free diet. Yes. Curtis, where are you? Ellen, you people are girls. So you have children, you know what to give them. We are men, we don't feed children that much.
Ellen
I know.
says that some of the gluten-free diets includes like some fresh fruits and sometimes some vegetables,
Yes.
and sometimes unprocessed meat or eggs do not
Okay.
include gluten, so they're
Gluten.
gluten-free. That is from
Okay.
the ladies, girls.
Okay. So they hide the lawyer. Okay. Yes. Any other point? If not, we move on. Yes.
Hello.
I've told you that I like to learn everything in the world, but when it comes to food and nutrition, I never like it. I don't know why. I don't like learning it.
Hi.
Yes.
Gluten-free food are food that doesn't have oats, have
Okay.
yes, oats, even malt. Some malt has gluten inside. Anything that has cereal, oats, wheat, that gluten
Okay.
foods, that food that contain gluten. There is some abbreviation. They use something like BOROW, BROW. They said oats, wheat. There is two that I'm forgetting,
Barley,
but
rye,
and barley,
Family.
yes, barley food,
Okay.
and then rye.
Okay.
rice, even pasta. Spaghetti contains. There's one question I encountered the other day. I saw spaghetti. I was quick to pick spaghetti, but later I realized that spaghetti is from grains, so it contains gluten
Ah,
too. Yes,
spaghetti is from Grace. Oh, wow.
it's
And
from flour now, flour from
yeah,
grain.
Sorry, you should be careful of what you eat. Romo. Then in your kitchen, everybody should write the gluten free. One thing is, nowadays, the restaurants, when you go, they will tell you this is allergies. So gluten, whatever, they will write. So you have to go and ask. And they'll tell you. If you don't know the things your body is allergic to, go and do DNA. If you do DNA, it will tell you this and these things your body doesn't like. Okay, this and this thing your body doesn't like. Go and learn your genes. Okay, all grains, all kinds of attitude. Okay, appendicitis. So that's inflammation. Then that's the last part of the intestine. Okay, inflammation of the appendix. You have periumbilical pain. Periumbilical pain. So the right lower quadrant pain at the magnetic point, that's sometimes the middle of it. Rebound tenderness. Okay. Fever. They are all part of the appendicitis. Appendicitis is a cheap one. It's a cheap topic, so I don't have to stress myself, right? Everybody knows it. Okay. Nail per os. Yes. Anytime you get issues with the GI tract and its accessory organs, NPO, NPO, NPO. Ask your doctor before you give the child or the patient something to drink or eat. Because majority of these gastrointestinal problems, we end up going to the theater. Okay, so don't rush to give them orals or anything oral. NPO is very important. IV fluids for hydration, antibiotics. Then you prepare for surgery. No enemas. Who can tell me why? Don't try enema for appendicitis. If you do that, you cause what?
So you increase motility, so you can easily burst.
Can easily rupture it. Enema stimulates gastric motility. And gastric motility is what? Contraction of muscles of the intestine. So you can burst. Laxative, don't try it. Or heating pad, don't try it. Okay. Yes. Now let's go to GU or renal. We have a lot to learn with pediatrics. I didn't give you the slide yesterday. Today I'll post it on the chat box. Everybody should learn a lot. And if you finish this journey with me, you are done. You just do cross. And then you admire pediatrics. Okay. So UTI, children mostly get it. More common in what? Infants and females. Okay. So children with UTI, poor feeding, fever, vomiting, irritability. Older children, dysuria, frequency, urgency, abdominal, and flank pain. So when this happens, you know that no, you are getting the infection is climbing, and it has climbed to what? The the kidneys. So pyelonephritis. Okay. So that is what you should know. Diagnosis, your urine culture is very important. Your clean catch or you catheterize them is very important. Okay. We have straight cut and we have other stuff. Okay. So we do. Then antibiotics, IV fluid intake. What? Yeah, from the kidneys to the ureters, from the kidneys, the collecting duct, the collecting chamber. Okay. The ureters, the bladder, the urethra. That's it. Women, females, take care of your girls well. Because man has a long urethra. So sometimes it's very difficult for infection to climb the urethra, even to the bladder. Talk of what? Climbing to the kidneys. So that's what you should know. So your urine culture can do your blood works. This is one of those simple topics. Still under gerontourinary, we have a condition we call the vesical urethral refluxing. VUR is a condition in which urine flows back to the bladder, into the ureters, and sometimes up in the kidneys instead of moving out through the urethra. So what caused it? UTI or renal scarring. This is my kidney. I have one here. I have one here. Okay. Inside the kidney. Whatever this the Bowman's capsule, this filtration will take on here. It will give it to the collecting duct. This collecting duct will give it to the ureter. ER, the ureter. Okay. The ureter will empty its content into the bladder from behind. There is no ureter in front of the bladder. They are all behind the bladder. Okay. Yes. So they empty and the urine is here. Now it is time for this urine to come out through this guy For some reason, here is blocked. It was an adult. We will start assessing the prostate. But it's a child. Children don't have issues with prostate. So where's the blockade coming from? There is possibly a stricture. That is why when children, we give birth to them, especially the male children, they are doing assessment. They want to see if the urethral meatus is there. Is the baby's diaper wet? Okay, because this one can sometimes close. And when they close, the heart of the child is always beating. So the urine blood will always, every time, every second, moves through the kidney. Okay. So we say that every second, kidney is what? Emptying urine. Okay. So this bladder, what do we say? The bladder is never empty. Unless the patient dies, the bladder or the kidneys shut down totally. The bladder is never, 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 never empty. Okay. Yeah. If you want the bladder to be plenty, give patient IV fluid. The urine to be plenty. IV fluid. You get the kidney will quickly, because once the kidney sees that the circulatory volume increases, it will drain more urine out. So girls, when they go to clinic and we give them bottle of water to drink, absorption of water in the stomach starts when? Tichubu, do you know? The fasting guidelines. Let me bring you closer home. Somebody is coming to the theater. He said that I have drank water. Okay. So your question will be, when did you drink water? Absorption of water. Water is inside your stomach. Water will cross to the small intestine. Water will be empty, or what the stomach will be emptying water. When? Who knows? I know IV, everybody knows. I'll bring you to the GIT. If I eat solid food, when does the solid food leave the body? If I eat liquid food, if I drink water, when does this water leave the stomach? Yes. How many minutes? Yes, who knows?
Well, just a guess. Could it be 6 to 8 hours?
Water. If water is taking 6 to 8 hours to leave the stomach,
Then how about food?
gastric emptying, you know.
Yeah, maybe 1 to 2 hours, 20 minutes, 20 minutes.
30 minutes upwards. That water should start leaving your stomach. Sharp. Okay. So girls, when you go to the clinic here, they want to take your urine, they will give you water to drink, because in the next 30 minutes, that water should start finding its way to the small intestine for absorption. And once the water comes to the bloodstream, again,
especially during abdominal pelvic scan.
Yes, especially abdominal pelvic scan.
Abdominal pelvic scan. Sometimes we want the bladder to
Yes.
full so that you can get the accurate results.
Yes. So you fill the bladder champion. But this child bladder is full. The diaper is not wet. So we start suspecting something is blocking here. And once the bladder becomes full, water looks for holes to pass through. Okay, so where this place is closed, where is the next hole? The next hole is here. It will start filling up. We call this one vesical urethral reflux. Sometimes there's another condition we call hydronephrosis. It is a brother to this condition. Okay, the water will come and get stuck here. Sometimes this ureter will also block. When this ureter blocks, that one, the urine will not even come to the bladder. It will be here. So when your kidneys are intact, they are draining or filtering the blood, bringing urine, but the urine is stuck in the collecting duct or the collecting chambers. Okay, so when you do a scan, you will see plenty urine here. You do CT scan, you see plenty urine here. So in that case, they'll go and put in a certain tube we call the urostomy tube to drain it out. So that's it. Okay. It is one of the most common causes of recurrent UTI in children. So those of you who believe in religion, that when you give birth, you don't want health workers to assess your babies. Struggle. Most children, this one mostly affects the male children than the females. Okay. Yeah. So the normal kidney flow, kidney, ureters, bladder, urethra, but your own is the reverse. It go to the bladder. Ideally, it should pass through your urethra out as pee. Okay. But when you get VUR, the reverse, when it gets to the bladder, it will turn its back. Now, where are you going? Bladder, ureters, kidneys. So it will cause a lot of infection to you. Sometimes the infection will even reach short. And water is what? A connecting, it will even help the bacteria to swim to the kidney so quick and fast. Okay, so that's it. Cause renal damage. So time voiding, and we adults sometimes we get it. Okay, sometimes we adults we get, especially adults who hold bladder for long. They don't empty it fast. You there, you have your nerves have developed. You have control over the nerves that supplies your sphincters. Okay, especially the external sphincter, urethral sphincter. Instead of you to wee or pee, you hold, you squeeze yourself, and the muscles will prevent. Yes, I mean, but it's very difficult. In adults, mostly sometimes get it, but they get it in the form of pyelonephritis. Okay, not vesical urinary reflux. Okay. Nephrotic syndrome. There is an increased glomerular permeability that leads to what? Massive proteinuria in children. This is my bloodstream. Okay. This is my kidneys. Inside the kidney, the basic unit, of the kidney is what we call the glomerulus. The basic unit of every human being is called what? Who knows? This is primary science, integrated science.
So
Okay. So that is why any disease that affects your cells, you are in trouble. It is very difficult to treat it. Every disease that whose target is to affect the nucleus of the cell, the power station, the nucleus of the cell. Example is what?
Hello, sir.
HIV is human immunoviral, and all these DNA viruses. Okay, they are going
Hello, sir.
straight. Yes. Dave,
I
do
wanted
you
to
want to
find
talk?
out. Yes, I wanted to find out the urine, the aspect of the urine that was flowing back. I wanted to find out the treatment for it. Oh, I didn't get that aspect well. So I wanted to just find out. I beg.
Oh, sorry. So we have prophylactic antibiotic in case of then we do surgery to open. Okay, so you know this, how do we call this team? The urology team. Yes, we have children who are born with the urethra closed. So they have some one instrument, they will come and put it in to open it. Okay. Yeah. So we do surgery if severe. Okay. Then we do antibiotic prophylaxis so that the child doesn't get infection. Because once infection climbs to the kidneys, they can shut off the kidneys for the baby or this child. Yeah.
Does it
So that is
account for the high rise of kidney diseases?
kidney diseases. There's so many factors that affect kidney nowadays. The food we eat, our lifestyle, okay, the medications we take counts, okay, the air that we breathe around us, what are inside those air affect us, okay. There's so many things. Kidney can sometimes is a direct injury to the kidney. Sometimes too, it is an opportunistic injury to the kidney. A certain problem has occurred somewhere now, like what we are going to do now. You understand the nephrotic syndrome. So kidney
Sir, for the
disease.
purpose of for the purpose of our health, when you feel your kidneys, your bladder is full, and you have to go and free it, you don't pull the urine because it is out of unwanted substance that the kidney has released to your bladder. You don't keep it because you don't have time. You keep it. Some people are fond of doing it. They'll keep it, and the more you are keeping, bacteria will build up. So when you are having the edge of emptying the bladder, quickly go and do so.
Yes.
Understand? To
Yes.
prevent other unwanted what do you call it, conditions that are unforeseen. Yeah, it's just a latter.
Okay. Yeah, so that is it. Okay. The kidney filters unwanted materials in the blood in the form of water. So don't think that water in your bladder is good. If it was good, the, the kidney will not filter it. Okay. That's it. And the funny thing is, when the glomerulus filters your blood into the urine, the collecting duct, okay, or whatever, it filters it. Glomerulus are filtered, the blood is gone on. Remember, we have the proximal tubules, the convoluted tubules, and the distal. Then the collection that comes here. Okay. So this one has filtered. Plenty blood is here. Or here. Or here. Plenty urine. Still, there will be reabsorption back into the, because this blood vessel that is gone, it will turn like this and come here. So when it reaches here, there will be reabsorption. That is why if you don't want to reabsorb it, you give a certain medication we call the loop diuretics. They will come and stand here and drain all the urine out. They will prevent this reabsorption, okay, and drain everything out. So when they get it like this, when the reabsorption takes place like this, these blood vessels will go and give it. They are arteries, but they are smaller arteries. We call them arterioles. They will go and give it to smaller veins. We call venules. And these venules will give it to the big veins. The big vein is called the vena cavas. But because this one is below the heart, below the heart, any big vein, this is my trick. This is not in any book. It's my trick. Any big vein below the heart, I call it inferior vena cava. Okay. The inferior vena cava. The inferior vena cava will send it back to the heart. So that is it. So that's the cycle. And every second is going on. Okay. Yeah. Okay. Nephrotic syndrome. So, oh, I shouldn't have deleted that structure. Okay. So the blood is bringing, the blood is passing by. They came to meet what? The glomerulus. The glomerulus is a network of vessels with their nice Bowman's capsule. Yes. When you take this glomerulus, it has a sieve. I call it colander. So that colander, or that cells here, like every other cell, it has a membrane that are not supposed to allow bigger structures to pass through. Okay, so this is a colander. Oh, that lady has passed her ankles. The girls, you have your colander in the house. Okay, when you prepare palm nut soup, you pour the soup, the palm nuts, the water, the chaff, everything here. And the colander, the hose, would drain only the liquid out and leave what? The palm kernels, the chaff. Okay. Yes. You are not supposed to see a palm kernel here. So the palm kernel is supposed to be in the bloodstream like this. So this is the blood coming. So palm kernels are supposed to cross and go. But you started seeing palm kernels here. What? What is going on with my colander? How big is my colander that this palm kernel has crossed and has sieved it? And I'm seeing it in my urine. When we go to the body or the bloodstream, the palm kernel is what we call proteins. Proteins, albumins, all these larger molecules, red blood cells, larger molecules. Look at the size of red blood cell, 80 to 100 femtoliters. Okay, is big that it should what? Contain hemoglobin. Enough hemoglobin, and inside the red blood cell hemoglobin. Inside the hemoglobin, there are what? Molecules, or they are receptors, 4 different receptors that will bind to oxygen. Okay. See this big red blood cell. Let us take your urine to the lab. We came back, red blood cell is in your urine. Protein is in your urine. How come? There is a trouble in my glomerulus. Was there infection that I did not see? Was there any infection I did not see that it has gone to widen or cause inflammation or this nephritis? Okay. Yes, that my protein is coming out, coming out, coming out, coming out. Okay, so you have this trouble. One, your glomerulus is widening. You are losing protein. This protein is supposed to stay in the blood. They help or hold water. Okay, why? Let me explain to you. The blood you see every day has what we call plasma. And the plasma, remember, plasma is coming from where? The cells. The cells releases water, or the cells, the water in the cell becomes plenty. There is a structure that drains some of the cells, the water, to the bloodstream. What is the name of that structure? Who knows? You cut your skin, you see a cell under your skin. Inside the cell, there is water, fluid. We call it intracellular fluid. They are not supposed to be a lot, plenty. Okay. But it becomes plenty. We can't leave it here. And we can't also allow it to destroy the cell and start draining around the cell. Okay. If it drains around the cell and it comes to this chamber, we call it what? Interstitial fluid. This one is what you see people, pida, edema, swollen, anasaka, and all these things. It means fluid has shifted from the cell or the bloodstream to the interstitial. So fluid is either supposed to stay here or stay here, and only a little will stay here in between to bath it. They bath the blood vessels, they bath your cells so that you look fresh and nourished. Some girls will even go and buy moisturizers. Okay, yes. So all these ones are there. But if these cells releases 12,000 liters, 12 liters, or let's say 20 liters of fluid, can the interstitial hold it? No. It has to come straight to the bloodstream. What is the name of this structure? This pipe? Pipe. Yes. Who knows? Who knows?
So please, can you come again?
This is your cell. This is your blood vessel. There is a structure that connects the cells to the blood vessels. That anytime there is plenty water inside the cells, this structure will drain some into the bloodstream. What is the name of it?
Lymphatic.
Come again.
Is it the lymphatic system or lymph nodes or something?
Lymphatic vessels is that one. You have the idea. I'll give it to you. Lymphatic vessels. Okay. That is why when this vessel develops a problem, you are in trouble. You get edema, a lot of people elephantiasis and all those stuffs. Okay. Lymphangiosarcoma, lymphangitis, whatever, plenty names, don't worry. When we get to lymphatics and the next batch, we are done long time. When you get to the next batch, if only you've not written English, you understand it. Okay. So, this fluid here, when this fluid travels from here to here, the name changes from intracellular fluid. In the lymphatic vessels, we call it lymph. The same fluid with different names. When it enters the bloodstream, we don't call it lymph, we call it plasma. It's fluid because it is water. It is coming with a certain pressure. We call it hydrostatic pressure. Okay. All these people who stay at places that are flood, when that flood, there's an overflow of a sea or whatever, dam or whatever. You see, when it's coming, you see the pressure it brings. The same thing happens to the plasma. When it's going, the lymph is flowing to the bloodstream. A lot of pressure. And if you don't control it, and if you don't hold this water, it will break and destroy the walls of the blood vessels. Or it will put a lot of pressure on the walls. That is why we have what we call blood pressure. Blood pressure. So the pressure of this fluid against the walls of the blood vessel is what we call. So the higher the pressure, the higher your blood pressure. Simple. So we call it hydrostatic pressure. Hydrostatic pressure. Okay. But it is God who created us. He knows what can happen. So he also created what? Something that will hold this water. Because if you don't do anything about this pressure and you don't hold it and calm it, it will destroy the blood vessel wall. So God created some larger molecules. We call it albumin. We call it what? Proteins, albumin, heterstarch, all this, plenty. The day we did IV freeze, you saw it. Okay. So they are in like this. They will hold the water like this and test it. The guy which is supposed to hold this water is now seeping out here. So now the water, we have less, like this. We have only 2 proteins here. All the protein is here. So over here, my glomerulus is destroying. I am losing protein, number 2. I have less protein in the bloodstream, number 3. Okay. The blood pressure is dropping. Why? Because the hydrostatic pressure now begins to gain power. So they destroy the cell and the walls of the blood vessel and open up the membranes, capillary membranes, or yes, and they sip, they sip, they sip, they sip, they sip, they sip. They are running away. The water is running away from the bloodstream to the interstitial. So you look at the patient is edematous, swollen, but go to the bloodstream, there is less fluid. Okay, there's less fluid. That's the problem. Yes. So just edema, periorbital edema, sometimes ascites, frothy urine, albumin level or protein level is low, cholesterol is high. So I need my steroids. Where's my steroids? I need my steroids. My diuretics to
Hello,
bring the
sir.
fluid. Yes, ma'am.
Please, why is the cholesterol high?
Okay. Who can answer? Cholesterol and albumin. Shoot. Who can answer? Nicole? Mm-hmm. 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 Oh, where's Aidin? Yes. I had a guy there.
I personally think when cholesterol is built up, it's due to lack of activity,
Yes.
active activity performance. So
Okay.
when it's built up like that, yeah, when the cholesterol is built up, it indicates of lack of activity due to the fluid retention.
Okay. Almost. Another guy. Albumin is low. Cholesterol is high. Chemo concentration.
Say, let me try. When the
Okay.
album is low, when it's low, for I think that the liver is trying to compensate until they're going to be spiked in cholesterol level in the system. That is by small analogy.
Okay. Somebody said the liver will concentrate. Somebody says sedentary lifestyle. Yes.
Hi,
What else?
can I try?
Bye.
Yes.
Okay, so I think the liver is responsible for producing proteins, right? So when there's a high demand in proteins, the liver will try to compensate, therefore resulting in high ammonia and high cholesterol. That's my thinking, though.
Okay. Yes. That's it. Consolo time.
Sir,
Are you okay now? Or if I don't talk, you won't be okay.
not too clear, please. Not too clear.
Okay. So where is your understanding to level 2? You say it's not clear, meaning it is clear in some parts, but superly not clear. So explain where the clearance is, so that we will also justify where there is no clear. Yes. Shoot.
Okay, so the clarity is in the fact that there's a inflammation in the glomerulus that increases the size of that increases glomerular permeability, thereby bringing out, excreting more of the proteins and then leaving less protein in the bloodstream. But why the cholesterol is high, that's where the confusion comes.
Okay. So it's like Clement and David Dems were saying, the liver does the production of all these guys. Okay. So when it produces it into the bloodstream, they will stay there. But the albumin, which is also supposed to stay there, will run away. Okay. So nobody has done anything to the cholesterol. Nobody has added cholesterol. But it is just, it is the albumin that has run away. So when you fetch your blood to the lab, you realize that concentration-wise, albumin has gone low. But cholesterol, it didn't change. There was no addition. But when we strike the fraction, you realize that cholesterol concentration has gone up above the albumin. Please, do you understand?
Yes,
Like the
please.
way we were doing this acid and base in the GI tract.
Okay.
If here is 100 and here is 100, because somebody was vomiting, here has become 50. But this one, okay. So you realize that the bicarbonate will be high Okay. The level has not changed though. It is maybe it's even within the same normal range. But when you strike the average, when you strike the comparabilities, you realize that the albumin, this one has reduced, and so we call it hemoconcentration. Sometimes somebody can be having, have you been hearing this word, dilutional hyponatremia, dilutional, this? Yes. You have sodium levels. The sodium is maybe 140 in the blood. It's normal. They are crystals, they are stones. It's normal, it's there. Nobody has touched it. But for all of a sudden, somebody went to give plenty Renges lactate. He has diluted this sodium. Okay. So it has been, the sodium level will go low compared to the water part. So we call it dilutional. It's like giving somebody plenty fluid to cause disseminated intravascular coagulopathies. The same thing happens with these two brothers too. Okay. They are all coming from the liver. But this one, let's say liver produce this 100 and produce this 100. Then all of a sudden, this guy has reduced to what, 50, because it is excreting through the urine. When I fetch the blood, these two, to the lab, I'll see that albumin has reduced. And because it has reduced, it has given, it's like it has sold the power to cholesterol. You understand?
Yes, please.
Somebody is asking, why would albumin run away? Yes, David. Somebody said, why will albumin run away? Yes, maybe the person just joined. Yes, we are learning nephrotic syndrome. Okay. You want to talk? Okay. Thank you. You talking about what? Okay. So albumin will run away because of the issues inside the glomerula. There is increased glomerular permeability. The membranes of the glomerulus should be semi-permeable, not highly permeable. So once it gives that semi-permeability vanishes, albumin will live there and come out. You see red blood cells, you see plenty things. And as they are living, it is a small hole, and you pushed a big molecule through it. Okay. Small hole, you put this big molecule through it. What will happen to this hole? Tomorrow, this hole will be wide a little. Then another albumin will come, push through it. This hole, will it be small again? No, it's going to be big. And the more you are pushing it through, you are causing injury. And the injury will come with what? The inflammations. Okay. These inflammations will heal, or the injury will heal. When it heals, we need new cells to come and replace the old cells that were injured. When the new cells are coming, because they don't want future injuries to occur, they will come with more stronger and more high pressure consuming cells that we call scar tissues. So yes, the scar tissues will come and form inside the glomerulus. And when they form, now albumin pass through. If you pass, injury will not occur. albumin, it cannot pass again. So at this stage, we say that what you are almost getting to, let's say, grade 4 or grade 3 kidney, chronic kidney disease or end stage renal. This thing will be going on. The glomerular will be destroying scar tissue formation, glomerular, the thickness will be destroying to a level that, I mean, it is totally destroyed. Then we have to put you on what dialysis to help you as filter your blood. Okay. So the steroids will come and take care for the inflammations. The diuretics will bring all the fluid from the interstitials back to the bloodstream. Okay. Then infection prevention is very key, so that you don't cause any future. So guys, are we done well? So tomorrow when we meet, acute glomerulonephritis, hypospadia. Okay. Then we enter endocrine. Okay. So follow me. How many systems have we got? Endocrine, hematologic. So come and learn. Yes, Clement, I'm coming. Keep your hands up. Hematologic. Okay. You learn sickle cell, hemophilia, leukemia in children, thrombocytopenia. Now we go to musculoskeletal. So dysplasia of the hip, DDH. We have clubfoot, scoliosis, fractures, osteomyelitis. Then we go to infections. So the measles, mumps, rubella. When are you supposed to give them vaccines? What are the symptoms that comes with it? Learn. Let's learn the difference between chicken pox and what? This guy, the other brother. Okay. Come and let's learn it. Okay, shingles. Okay. Which one will the body form immunity forever? And which one can happen again in future? Come and learn. Viral infections. Pertussis, respiratory syncytial viruses. Come and learn. COVID-19, children, pediatrics. Then isolation precautions. Then we look at the CDC immunization for children, hepatitis B. So your child should have this. Okay, if you have forgotten. Then the live versus inactive vaccines. So NCLEX or your examination will test you. Okay. Then the contraindication, the post-vaccines, and all those stuff. Then we go to pharmacology in pediatrics, how to calculate their doses with their age and all those requirements, the safetiness. Okay. High-risk medication in pediatrics, antibiotics in pediatrics, antipyretics in pediatrics, bronchodilators in pediatrics, insulin in pediatrics. Then let's go to the ED, emergency department, and critical care, ICU. So a child will come with pediatric shock. What are the types of shock? You go through. Then if you want to do CPR, what are we supposed to do? A mother has brought a child with asthma. We have treated. Within a short time, asthma is recurring again. Status has set in. How do we go about it? A child was born with type 1 diabetes. He is now having complications of DKA. At the emergency unit in the ICU, how do you treat it? Pediatric trauma. Somebody refused to put a seat belt for the child. There is a car crash. There is trauma. What type of levels come? Level 1, level 2, level 3, level 4. Okay. Then psychosocial, mental health, and chronic illnesses. So come and let's do psychiatry as well. Okay, family-centeredness. Then coping with chronic illnesses. So all this autism and all those stuff. A child has got cancer. We have done everything we could. We did not see. Now the cells have become metastatic. It has started invading because every cancer cell has the ability to invade surrounding tissues and organs. It is causing multiple organ failure. Now let's prepare the child, depending on the age, the parents of the child, the siblings, the cousins, the aunties, on end of life care. Okay. The nurse, how do you go about it? How would the family accept this? A child is saying that I want you to take me to the aeroplane, to sit in an aeroplane before I die. What are the things you would do to make this arrangement? Somebody is saying he wants to greet the president of Ghana before he dies. What can we do? End of life considerations in pediatrics. Okay. Then child life support, so therapeutic and all those stuffs. Then when you are working in the pediatric environment, what are the legal issues with them, with their nursing? And what are the ethical issues? The ethical dilemmas. So Clem is going to Clem is stuck between two issues. Ethical. What are they supposed to do? She is confused. Whom is she supposed to consult for what? Assistance. These are the things, the assent and the consent, emancipated minors, mandatory reporting, confidentiality in adolescent, then NCLES pediatric priority framework. So when you are in trouble, we have this, and this one, those of you who are going to write NCLES, memorize it. Because you will come. What are you supposed to do? Developmental age over chronic age. Okay. Will help you. Safety will always come before growth and development. If we want to intervene, the least restrictive will come first. Family-centered care is very important. Then this one, we've done it already, just for you to. Separation anxiety and stranger anxiety. They are toddlers. So regression, effect of hospitalization by age. When an infant is hospitalized, how do they understand it? Yes, in the preschooler, it goes by that. Pediatric communication techniques, then the traps, then we say goodbye. Now, Clem, ask your question. Let's go.
Okay, so you talked about giving diuretics to nephrotic syndrome, glomerulonephritis. So you said giving the diuretics is going to bring the water back into the veins, right? So I wanted to know, is it not going to excrete it out, but leaving it in the veins or something? I didn't get that place, so I wanted to clarify that one.
Yes, so they are used to manage fluid overload or tissue edema. You understand? So this is the bloodstream. Okay, this is your cell. Fluid has to run away from here to here, and it's caused. And this is the interstitial fluid, ITF. And these are the cell, and this is the blood. So there is edema here. Okay, there is edema here. This this diuretics we sometimes give to bring the fluid from here to here. Okay. When it brings it from here to here, remember, the blood vessels will take it to the kidneys, and the kidneys will excrete it. Somebody has gotten pulmonary edema. The fluid was supposed to stay in the pulmonary arteries, but because of hypertension, remember, because of high hydrostatic pressure, fluid has shifted from the arteries to this side, and oxygen cannot go, carbon dioxide cannot go. What do I have to do? I give my diuretics. It has the ability to bring all the water from the tissues to the bloodstream. The bloodstream will bring it to the. Do you understand?
Yes, I get it. Thank you.
So that is it. Yes. So if you are not part of our group, make sure the link is on the page. Make sure you join, and our YouTube channel too, please. Make sure you join. Okay. Yeah. Very soon we'll be doing live YouTube's discussions. So we put the topic on the page. We do discussions. So make sure you join, you subscribe. So everything we put there, you get a notification. A notification so that you can take advantage of it. Okay. Yes. You asked for the slide. I'll give you the slide. Pediatrics. Oh, right. So that's the slide. Posted the slide to the chat box. It is less than 1 megabyte, 821 kilobytes. So get it. If you want the recordings, it's on YouTube or Facebook. Go and watch it. Okay. Go and watch it. So that we save our iCloud for future things. Okay. Yeah. So go and watch. Ayariga has posted the channels there. Click on it, YouTube, Facebook, go and watch. If you go and watch, you subscribe to the channel, then you also share it for people to benefit. With that, everybody will benefit. Okay? Thank you so much. God bless you. Bye-bye.